عليكم السلام
Hello.
دكتور.
Okay, today is the last lecture for anatomy. So, in this last lecture of anatomy, we'll discuss the development of the whole of the gastrointestinal system (GIS). So, this lecture will mainly deal with the development. Okay, so the objectives covered will be the development of the esophagus, stomach, small intestine, as well as the large intestine. Then the congenital anomalies related to the esophagus, the stomach, small intestine, as well as large intestine, as well as the development of liver, pancreas, and their anomalies. As you know, if you remember, go back to your level 3. There we had discussed that the development of the gastrointestinal system is from the yolk sac. The yolk sac, this is the embryo developing. Here will be the amniotic fluid, and here will be the yolk sac. Initially, the yolk sac will be large, but with the head folding and the tail folding, this yolk sac becomes small and small, and this becomes the yolk stalk, and a part of the yolk sac incorporated into the folding embryo that will form the gut. So the digestive tube is formed from the yolk sac. The yolk sac, which is inside, which remains inside, that will form the GIS, that is the gastrointestinal system or the digestive system. The endoderm form the epithelial lining of the alimentary canal. As you can see here, a part of the yolk sac here, it goes inside and it forms the endoderm. It forms the endoderm, and that will form the epithelial lining of the whole of the GIT. As you can see here, the upper part near the head, this is called as the foregut. The middle part will be called a midgut, and the lower part will be called as the hindgut. As you know, the development of the whole of the digestive system is from the foregut, midgut, and hindgut. So there are three parts of the digestive system. So the endothelial lining form the epithelial lining of the alimentary canal. Okay, while this splanchnic mesenchyme form the surrounding muscles and the serous coat. Around that will be the splanchnic mesoderm, which will form the muscles and other parts of the GIT. The main endothelium lining will be from the yolk sac. Okay. The developing gut is divided into foregut, as I said before. It is divided into three parts: foregut, midgut, and the hindgut. The esophagus develops from the upper part of the foregut, as you can see here near the mouth. Here will be the mouth. So this is the developing head, and here is the mouth. Near that mouth will be the foregut. So the esophagus develops from the upper part of the foregut, which extends from the laryngotracheal groove to the fusiform part of the stomach. So from the beginning of the larynx, that is the end of the pharynx. Okay, from the larynx up to the fusiform part of the stomach. This is the fusiform part of the stomach. So from here to here, this will be the esophagus, which is developing from the foregut. At first, it is short tube, but when the heart descends, it elongates rapidly. So initially, it will be a short tube, but as the human being becomes straight, vertical, and his neck becomes long as well as his body grows, this esophagus also grows to a large extent. So initially, it will be very short, then it will grow long. Okay. Uh, Now coming to some of the important anomalies. As you know, the esophagus develops from the foregut, that you should remember. Now coming to the congenital anomalies. What are the anomalies related to the development of the esophagus? One is the atresia or the stenosis of the esophagus. Normally, this is the esophagus. Sometimes there will be atresia, means closure. So it is not developing. Sometimes this will totally close and it form called as the atresia, or it is also called as the stenosis of the esophagus. Atresia or the stenosis of the esophagus. Sometimes there can be tracheoesophageal fistula. So sometimes trachea is behind. This is the trachea, which is the part of the respiratory system. Okay, it opens into the two lungs. So sometimes there can be a fistula, means connection between the trachea. Normally there is no connection between the esophagus and trachea. So the trachea is just behind the esophagus. But here, if you see here, the trachea is actually in front of the esophagus. Esophagus is behind. Okay. So sometimes Because of the congenital anomalies, the esophagus might open into the trachea. This joining of the trachea with the esophagus, this is called as the tracheoesophageal fistula. There are different types of fistula, as you can see here. This is one type, the other type is here. So the thoracic part has opened into the trachea, and the remaining part of the esophagus is beginning from the trachea. Okay, so the food can enter in these conditions, will enter into the respiratory tract, that is the trachea. So this is called as the tracheoesophageal fistula. This is also a type of the tracheoesophageal. All these are the three types of the tracheoesophageal fistula. Then there can be congenital short esophagus. Sometimes the esophagus becomes very short. As I said before, initially the esophagus will be short. Later, as the growth of the body takes place, the esophagus become long. Sometimes it might remain very short. Okay. So here also this is a type of fistula of the tracheoesophageal fistula. Or these are the different types of fistula. Here there is total atresia. There is no fistula, total atresia in the middle part of the esophagus. Okay, so these are some of the congenital anomalies of the esophagus. Now coming to the development of the stomach. So this is the stomach develops from the foregut as a tube in the middle line from the foregut. As you can see here, the lower part of the esophagus dilates itself, which is also from the foregut. It forms a fusiform structure here. Okay. Okay, so initially it will be a tube-like. It appears as a tube in the middle line from the foregut. It has a ventral and dorsal mesentery. If you see here, it will have a mesentery called as a ventral mesentery. That is called as the in front. Ventral means anterior in the front, and dorsal means posterior. So there are two mesenteries for the stomach. Usually, as we have seen for other parts of the intestine which has a mesentery, it will be just posterior, that is the dorsal mesentery. But in case of the stomach, there is ventral as well as dorsal mesentery initially. The stomach tube dilates and forms fusiform. As I said, initially it will be tube, later it dilates to form fusiform shape. This is the fusiform shape of the stomach. Its dorsal border elongates more and forms the greater curvature. As you can see here, the dorsal border, the posterior border, elongates to form the greater curvature. So initially both will be same, but later the dorsal border develops much more faster to form the greater curvature, while the ventral border form the lesser curvature. The ventral or the anterior border remains same, so this becomes the lesser, shorter. So this grows more, so that's why it's called a greater, because it becomes bigger. Okay. The fundus appears as a dilatation at the upper end of the stomach. As you can see here, in the upper part of the dorsal border, where there is growth, much more growth, there the upper part of the greater curvature of the stomach form the fundus of the stomach. Now the stomach rotates 90 degrees to the right. Initially it will be vertical, then it starts rotating. If you see here, so this is the cross section. If you take a section of the stomach, so this is how it looks like. Here is the stomach. In the front we have a ventral mesentery. Here there is dorsal mesentery. So this is, as you can think, this is the anterior abdominal wall. This is the posterior abdominal wall. Now if you see here, it starts rotating 90 degrees. 90 degrees. So the stomach rotates 90 degrees to the right. The left and the right surfaces become anterior and posterior surface. So the right, and so here will be this. So this will be the anterior, this is the posterior. So this will be the right, and this will be the left surfaces. Now they become the anterior surface and the posterior. So with this rotation, so instead of right and left, now it becomes anterior and posterior surfaces. The ventral and dorsal mesentery form the omenta and the peritoneal ligaments related to the stomach. So now this ventral mesentery and dorsal mesentery become the peritoneal ligaments. Peritoneal ligaments. We'll talk about that. Which are those ligaments? Okay. So these are nothing but the ventral and dorsal mesentery, nothing but the mesentery, as you know. Okay. Now coming to the congenital anomalies of the stomach. Okay. Sometimes the stomach uh, the growth of the curvatures. As we saw, there will be growth of the anterior and posterior curvature, the anterior and posterior border to form the lesser and greater curvature. Sometimes instead of growing, they degenerate, and here you can see there is degeneration of stomach, and it looks like a hourglass. So that's why it is called as the hourglass stomach. Hourglass stomach. You might have seen hourglass in case of the sand is put on the top and it will be flowing through it. Okay, so it looks like this, similar to this shape. So that's why it is called as the hourglass stomach. On the other hand, this is more common in case of children where there will be stenosis. As we saw the stenosis in case of the esophagus or the atresia or the stenosis, similarly there can be narrowing of the especially the pylori part of the stomach. So this is called as the pyloric stenosis. Stenosis. Here if you see here, this is narrowing. This is the regular opening. But here if you see here in near the pylori part, it is stenosis. This is called as the congenital hypertrophic pyloric stenosis. This is more seen in case of the children. Okay, so this is called as the congenital hypertrophic pyloric stenosis. Now coming to the development of the duodenum. After the esophagus and the stomach, we will talk about the duodenum. Duodenum is developed from the foregut, the caudal portion of the foregut, and the proximal from the this is there is a reverse. The proximal portion should be from the foregut, and the caudal part from the midgut. Okay, actually, okay, so this is right. Okay, caudal portion of the foregut, so means the lowermost part of the foregut and the proximal part of the midgut. So the lower part of the foregut, and this is the upper part, proximal part of the midgut. So this duodenum is developed from two structures. So the lower part, that is the caudal part of the foregut, the lowermost part of the foregut, and the upper part of the midgut. Okay, because duodenum has the junction between the foregut and midgut. We'll talk about that. The major duodenal papilla lies at the junction of these two portions. So the major duodenal papilla, as you know, major duodenal papilla is the site where the pancreas will open. Okay, pancreas as well as the even the bile duct opens. So that is called a major duodenal papilla. So that is the junction which indicates the junction between the foregut and midgut. Okay, so as you know, the duodenum develops from two parts, foregut as well as midgut. Okay, and this junction between the foregut and midgut is defined by the major duodenal papillae. The duodenum is attached to the back of the midline by the dorsal mesoduodenum. Okay, so there will be the dorsal mesoduodenum in case of the initial part of the development. The duodenum rapidly grows to form C-shaped loop, which is convex ventrally, as we have know. So here, if you see here, this is the duodenum developing. Here is the stomach, and here is the junction between the foregut. This is the foregut, and here is the midgut, and this junction is indicated by the opening of the major duodenal papilla. Okay, so if you see here, so this is the part. So initially there will be dorsal mesoduodenum. If you see here, there will be a mesentery called as the dorsal mesoduodenum. Okay. The C-shaped loop rotates 90 degrees to right with the stomach rotation. As you can see here, slowly it starts becoming C-shape. So initially we a long tube. Later it becomes start forming C-shape. As you know, it has four parts: first part, second part, third part, and fourth part. So it starts forming the C-shaped structure. Okay, and it also starts rotating. As you have seen the stomach, when the stomach rotates, even this part of the duodenum also rotates to 90 degrees. The C-shaped loop rotates 90 degrees to the right with the stomach rotation. After rotation, the right layer of the mesentery disappears and the duodenum becomes retroperitoneal. After its rotation, this mesentery, which is present for the duodenum, it disappears. Now it becomes retroperitoneal. So as we know, retroperitoneal means without peritoneum, behind the peritoneum. So it is behind the peritoneum. Okay, so initially it will have a mesentery during development, but with rotation, it totally disappears. This mesentery disappears, and now it becomes retroperitoneal. So if you see here, this is the development of the the duodenum. If you see here, here is the duodenum. In the front, we have the ventral pancreas and dorsal pancreas. We'll talk about that. Okay, there are two pancreas initially. So ventral pancreas, ventral pancreatic duct, and dorsal. Later, both will join to form the pancreas. Okay, we'll talk about that. But during its rotation, the ventral pancreas goes and joins with the dorsal pancreas. So there is one pancreas. Now the duodenum, which had a mesentery, dorsal mesentery, now it starts rotating with the rotation of the stomach, and it goes behind the peritoneum. Now it becomes retroperitoneum. It is totally attached to the posterior abdominal. This is the posterior abdominal wall. This is the anterior abdominal wall. Initially, it will have two mesentery, ventral and dorsal. Now, with the rotation of the first, there will be pancreas joining with the dorsal pancreas. Then there will be rotation of the gut. So by that, it goes, becomes the retroperitoneum. Both the duodenum as well as the pancreas become a retroperitoneum. Now there is no mesentery for them. Okay. So initially it will have mesentery. Later, both the ventral as well as dorsal mesentery disappears for the duodenum. An endodermal hepatic diverticulum develops from the ventral wall of the duodenal loop called as the bile duct. As you can see here, so if you see here, this is, as I said, there are two buds. Okay, and here if you see here, there is a liver bud developing in the front. Okay, so now we are talking about the development of the liver. So near the development of the, when we start the development of the duodenum, in the front, in the part of the duodenum, we can see a development of a bud called as the liver bud here. And here there is bud for the gallbladder. And we also have the pancreatic bud, ventral and dorsal pancreatic bud. Okay. So the endodermal hepatic diverticulum, the liver development develops from the ventral wall of the duodenal loop. So it develops, the liver develops from the ventral anterior part of the duodenum. Okay, where there is also development of the bile duct. The hepatic duodenum grows ventral and cranial to enter the ventral mesentery. So as we have seen initially, there will be a ventral mesentery. So this liver develops within the ventral mesentery. Okay, liver bud which is developing into the ventral mesentery. Okay, it divides into two parts, pars hepatica and pars cystica. So it divides later into pars hepatica from where the liver develops and pars cystica from where the gallbladder develops. So initially it will be single bud, liver bud, then it divides into pars hepatica and pars cystica. The pars hepatica form the common hepatic duct. It divides into right and left hepatic ducts. The cranial end of the hepatic duct divides to form the liver cells. So if you see here, the cranial part is dividing to form the hepatic liver cells, and the distal part will form the hepatic ducts. Okay, right and left hepatic ducts. So here this is the same is grown here into the duct, the common hepatic duct and right and hepatic duct, and above will be the liver. Liver is not shown here, but it will be developing into liver. The liver stroma is derived from the ventral mesentery. As I said, the liver bud will be developing from the ventral mesentery, the front here. So here is the liver bud. You can see here it is developing into the hepatic ducts, and then there will be formation of the liver in the top. So it is developing in the ventral mesentery. For this, there will be ventral mesentery, but the lower part will disappear. In the lower part, the mesentery totally disappears. But for the liver, there will be mesentery. Okay. So the liver stroma is derived from the ventral mesentery. The pars cystica gives rise to cystic duct and the gallbladder. As you can see here, the pars cystica, this is the pars cystica, which develops into gallbladder and cystic duct. The duct of the gallbladder, that is the cystic duct. It develops from two buds, the pancreas. Now we are talking about the pancreas. Here you can see here the pancreas as we discussed before. So it develops from two buds. One is the dorsal pancreatic bud and the ventral pancreatic bud. This is the dorsal pancreatic duct. This is the ventral pancreatic. Again, at the same junction where the liver has developed, so the pancreas also develops. The dorsal pancreatic bud form the dorsal wall of the duodenum. So it develops from the dorsal wall of the duodenum. The ventral pancreatic ducts from the proximal end of the hepatic diverticulum. Near the hepatic diverticulum, the pancreatic ventral pancreatic duct will develop. The two buds come close together in the concavity of the duodenum. Initially, they will be separate. Later, they all both will join together, as we have seen. So there will be rotation. So the ventral pancreatic duct goes behind and joins with the dorsal pancreatic duct. Okay. So here you can see here. So it will goes and joins later. We'll see. So it will goes and joins, and it has become one pancreas. Okay. The dorsal bud elongates faster and forms. So the dorsal pancreatic duct will elongate faster, bigger, and it forms the head, the upper part, especially the upper part of the head, the neck, body, and the tail. Most of the parts of the pancreas are developed from the dorsal pancreatic duct. So most of the pancreas is derived from the dorsal bud. Okay, from the dorsal bud. So what develops from the ventral bud then? The uncinate process and the inferior part of the head. So the main upper part of the head will be developing from the dorsal bud. So the lower part, that is called as the inferior part of the head, will develop from the ventral pancreas, as well as even the uncinate process. As you know, the pancreas has a process called as the uncinate process. So the uncinate process develops from the ventral bud. Now coming to the congenital anomalies of the pancreas. What are the congenital anomalies? One is called as the annular pancreas. As you can see here, during its rotation, if it doesn't rotate properly, it will cover the whole of the pancreas, the duodenum, and it narrows the duodenum. As you can see here, the pancreas has totally covered the duodenum, and the duodenum has become very narrow. So this is called as the annular pancreas. Annular means around. So it forms a ring around the duodenum. So this is called as the annular pancreas. Sometimes there can be ectopic pancreas. In some of the conditions, there will be small pancreas in different parts. Okay. And that can lead to a lot of complications. Okay. So the ectopic, that is called as the ectopic pancreas. If it is not in this proper position and present in some other parts of the GIT or somewhere else, then it is called as ectopic pancreas. So one is the annular pancreas, the second is the ectopic pancreas. Now coming to the development of the small intestine. So the small intestine, it is slightly complicated thing where there are different stages of development of the small intestine. Okay, there are especially 5 stages of development of the intestine. So what are the 5 stages? The first is called as the pre-herniation stage. Pre-herniation stage. Initially, if you see, the intestine starts protruding out of the abdomen. Initially, before the protrusion, the initial stages when the intestinal contents try to protrude out of the abdomen, that is called as the pre-herniation stage. Then the second stage is the stage of physiological umbilical hernia. So in the second stage, all the intestinal contents will come out through the umbilicus. This is normal. That's why it's called as the physiological. It is not pathological. It is physiological stage of umbilical hernia, where the intestinal contents of the abdomen come out. Okay, then there is third stage called as the rotation of the midgut loop. As we have seen, the stomach rotates, the duodenum rotates, the whole of the midgut will rotate outside the abdomen. It will come out and it will rotate. Okay. Then the fourth stage, it will go back to the stomach. This is called as the stage of reduction of the umbilical hernia, where the intestinal contents will go back with the development of the abdomen. So the intestines will have the space to go back. Initially, because of the excessive growth of the intestine, they will come out. Okay. So you might see in the future, you might see clinically some of the babies newborns with the intestinal contents outside the abdomen. Sometimes there can be intestinal contents coming out and they don't go back. There is no reduction. So sometimes there might be growth of the newborn with the intestines outside. This is because you should know this was the initial stage of development which did not complete. Maybe it did not complete due to some complications and the intestinal contents are outside. Okay. So Normally, there will be reduction of the intestinal content. So this is called a stage of reduction of the umbilical hernia, where the intestines will go back into the abdomen. And the fifth stage is the stage of fixation of the various part of the intestine. That is, they will go back to their proper positions. As you know, the proper positions: the liver will be on the right side, the stomach will be on the left side, the ascending colon, transverse colon, descending colon. Ascending colon will be on the right side, descending colon on the left side. All these positions are set by the stage of fixation. Okay, so these are the five stages of development of the small intestine. First is called as the pre-herniation stage, before the intestines come out of the abdomen. Okay, that is called as pre-herniation stage. Then the stage of physiological umbilical hernia, where all the intestinal contents will come out because of the excessive growth of the intestine, but there is no growth of the abdominal cavity. So all the intestine will come out. Then there is third stage called a stage of rotation of the midgut loop, so where there will be rotation of the intestines. The fourth stage of reduction of the umbilical hernia, where there is growth of the abdominal cavity now, so all the intestines will go back into the abdomen. So this is called as a reduction stage. And the fifth stage is the stage of fixation of the various parts of the intestine. So where the all the intestine and other structures within the abdomen, they will set into their normal position. That is called as the stage of fixation. So these are the five stages of development of the small intestine. Now coming to the development of the midgut loop. Okay. By the beginning of the sixth week, the midgut elongates to form the ventral U-shaped midgut loop. If you see here, so here there will be formation of something called as the U-shaped ventral midgut loop. The midgut loop communicates with the yolk sac, as you can see here. It will start communicating with the yolk sac by the vitelline duct. Here, if you see here, this is the vitelline duct. Yolk sac will be outside, and it will be smaller here at this stage. Or the yolk stalk. You have seen already the yolk stalk before. So if you remember this picture, so here is the yolk stalk. Okay, so the midgut starts communicating with the yolk sac through the yolk stalk, or now it becomes very small here. Now it is called as the vitelline duct. Vitelline duct. Okay, so if you can see here, this is the vitelline duct now. Okay, midgut loop starts communicating with the yolk sac by the vitelline duct or the yolk stalk. As a result of rapid growing liver, kidneys, and gut, the abdominal cavity is temporarily too small to contain the developing rapidly growing intestinal loop. So the midgut loop projects into the umbilical cord, which is called as the physiological umbilical herniation. Okay, so as I said, because the cavity of the abdomen is very small and the intestine grow very fast, so they will all come out through the umbilical cord. So this is called as the physiological umbilical herniation, as we studied here. Okay, stage of physiological herniation. So the same stage has been described here, beginning by the sixth week. Now once they come out of the abdomen, so this is, if you imagine, this is the umbilical cord. So the intestine are coming outside of the umbilical cord because of the excessive growth. Okay, so now there will be rotation of the midgut loop. So now there goes, they come out, then there is rotation here. If you see here, there is rotation. The midgut loop has a cranial limb and a caudal limb. If you see here, there is the cranial limb. This is also called a cephalic limb, or the cranial. Cephalic means head, cranial means also head, and caudal means toward the tail. So there is cephalic or the cranial limb and the caudal limb. So there are two limbs for the midgut. This is the midgut. The midgut loop rotates around the axis of the superior mesenteric artery. Here is the superior mesenteric artery, and in that axis it will rotate. If you see here, now it has rotated. The midgut loop rotates 90 degrees to the right, so that the cranial limb becomes the right and the caudal limb becomes the left during the physiological herniation. Initially, the cephalic will be on the top and the caudal will be below. Now with 90-degree rotation, they become right and left during the physiological herniation. The cranial limb of the midgut loop elongates to form the intestinal loops, jejunum, and the ileum. So this was on the top here, cephalic. Now with the rotation, it has come down on the right side. Now this will form the intestinal loops. Okay, this cranial limb, which was on the top initially, with the rotation it has come down, and now this form the jejunum and ileum. It is the part parts of the small intestine. This rotation is counterclockwise and is completed to 270 degree. Then it will have counterclock rotation of 270 degree. So after reduction of the physiological hernia, it rotates to about 180 degree. So there is a reverse rotation of 270 degree. So initially there will be rotation of the 90 degree on the right side. Then there will be reverse rotation of 270 degree. So it becomes 180 degree. So when it goes back into the abdomen. Now, coming to the return of the midgut loop back into the abdomen. So now, as the abdomen cavity grows faster, now all the intestine will come back into the abdomen. If you see here, it has come back. It had come out. Now it is going back into the abdomen. Okay, so this is called a return of the midgut loop to the abdomen. During the 10th week, the intestine returns to the abdominal cavity. It comes out the intestinal cavity at the 6th week. As we saw, it will come out. Physiological hernia takes place at the 6th week. 4 weeks it will remain outside the abdomen. Then by the 10th week, it will return to the abdominal cavity due to regression of the liver and the kidney and expansion of the abdominal cavity. Because of the expansion of the abdominal cavity and the liver becomes smaller and the kidney, so and the increased growth of the abdominal cavity, so now there is space in the abdomen, so they will go back into the abdominal cavity. It is called the reduction of the physiological midgut hernia. As we have seen, reduction of the physiological midgut hernia. Rotation is completed and the coils intestinal loops lie in their final position in the left side. So now they will go back and they get reduced back into their normal position. They return back and they are fixed into their normal position. The cecum at first lies below the liver, but later descends to lie in the right iliac fossa. You see here, initially here is the liver developing. So here is the cecum. Okay, just below the liver is the cecum. Later it will descend downwards. This one downwards to go back into the right iliac fossa. Now coming to the fixation of the various parts of the intestine, as we have seen, so initially they will be in the different positions, then they will get fixed into their proper positions. Okay. The enlarged colon presses the duodenum and pancreas against the posterior abdominal wall. Okay. So if you see here, the duodenum and the pancreas, as we have seen, they will lose their peritoneal coverings and they become retroperitoneal. Okay, the most of the duodenum mesentery is absorbed, so most of the duodenum. So if you see your the first part, the first, second, and third part of the duodenum, except the last part, that is, except in the last first 1 inch, all of the duodenum become loses its the mesentery, and the pancreas becomes retroperitoneal. So both the duodenum and the pancreas become retroperitoneal. As you can see here, they have become retroperitoneal. But the other parts of this is the transverse colon, this is the small intestine, all have the mesentery. Okay, but the pancreas and duodenum has gone and get attached to the posterior abdominal wall. Now here you can see how the intestinal contents have come out. This is how it is. If the baby is born with the intestinal contents outside. Okay, if there is no physiological fixation and return of the intestinal content, then this is how it looks like. So this is called as the congenital omphosis. This is called as the congenital omphosis, where the intestinal contents have come out of the abdominal cavity. They rotate, but they will not go back into the abdomen. So they're covered by, this is the amnion, so which is covering this, as well as the umbilical cord here. So here you can see here is the amnion covering the. So here is the amnion covering the intestinal contents. All the intestinal contents are inside, and here you can see the umbilical cord. It is a persistence of the herniation of the abdominal content. As I said, normally they have to return back. That is called as a physiological return, physiological herniation and the return and fixation of the intestine. Sometimes there is persistence, means they will not return of the hernia of the abdominal content into the proximal part of the umbilical cord due to failure of reduction of the physiological hernia. So if there is failure of the reduction of the physiological hernia to the abdominal cavity by the 10th week, so it will remain outside. So herniation of the intestines occur in 1 of 5,000 birds. So this kind of failure of reduction will take place 1 in 5,000 birds. Okay. And herniation of the liver and intestine occurs in the first 1 of the 10,000 birds. Herniation of liver, this is the herniation of the intestine, 1 in 5,000. But sometimes there can be even herniation of the liver and intestine together. It occurs 1 in 10,000 births. 1 in 10,000 births. You can see such kind of failure of reduction of the physiological hernia. Okay. So you should know if there is such kind of conditions. You should know that normally it has to return back. Usually it is normal that it will come out of the intestine will come out of the abdomen, then they will return back into the abdomen. If there is failure of reduction, then you can see the congenital oncosis. It is accompanied by small abdominal cavity. As we know, if there is no growth of the abdominal cavity, the intestine cannot go back. Okay, that's why you can see small abdominal cavity. The hernial sac is covered by epithelium of the umbilical cord and the amnion, as we have seen. So the covering of the amnion. Here you can see here it is covered by amnion, and you can also see the umbilical cord. Immediate surgical repair is required. So such kind of births with the congenital oncosis needs immediate correction, immediate surgical repair. Okay, after the birth of the newborn. The congenital umbilical hernia, sometimes the congenital umbilical hernia, the intestine returns to the abdominal cavity by the 10th week, but herniation through an imperfect closed umbilical cord, umbilicus. So this is the omphosis. Sometimes there can be smaller herniations through the umbilical cord. Okay, so this is the peritoneal hernia sac. Sometimes the part of the intestine might be seen, sometimes something else. Okay, so this is called as the congenital umbilical hernia. Apart from the omphosis, omphosis is complete intestine coming. Sometimes there can be a part of it is coming out. Okay, so the intestine returns to abdominal cavity by the 10th week normally, but herniation through an imperfectly closed umbilicus, then you can see these kind of herniations. It is common type of hernia. So this is one of the types of hernia. As you know, there are different types of hernia. There are the inguinal hernias, femoral hernias, and the umbilical hernia is also a type. So this is the umbilical hernia. The herniated contents are usually the greater omentum or the small intestine. As I said, through this small herniation, you can see sometimes the peritoneal, only the peritoneum, sometimes the intestine, sometimes some other omentum, something like that. Okay. The hernial sac is covered by skin and subcutaneous tissue, because outside still we have the skin and the subcutaneous tissue. It is always covered by the skin and the subcutaneous tissue. Here, if you see here, there is no skin and subcutaneous. It is only covered by the amnion. So because it is at the very early stage, so this is covered by amnion. But here, normally, if there is congenital hernia, other types with small intestine coming out, then it is covered by skin and the subcutaneous tissue. It protrudes during crying, especially if there is small kind of this kind of hernias. Whenever the baby cries, it will protrude out. Sometimes it will return back, and whenever the baby cries, it will return. Okay, so it protrudes during the crying, straining, or coughing, and can easily be reduced through the fibrous ring at the umbilicus. There is a ring here near the umbilicus. This is the fibrous ring, so it can be easily reduced in this kind of conditions. It can be easily reduced, and it protrudes whenever the baby strains or cries or coughs. Surgery is performed at the age of 3 to 5 years. In these kind of cases, you can do the surgery 3 to 5 years after. But here, in these conditions, where there is congenital oncosis, it should be done immediately after birth. So here you can see a baby with a small umbilical hernia. Okay. Here also you can see a baby with a small umbilical hernia. So these are the umbilical hernias, and this is a major type where there is congenital oncosis. Okay. Now coming to something called as the Michel's diverticulum. Michel's diverticulum. Okay. So if you see here, So here is the umbilicus. Just behind the umbilicus, you can see this small projection coming from the ileum. This is called as the Michel's diverticulum. Okay, and it is attached to the anterior abdominal wall by vitelline ligament. It is one of the most common anomalies of the digestive tract, present in about 2%, 2 to 4% of the people, more in males. More in males, this kind of Michel's diverticulum is seen. It is a small pouch from the ileum, and may contain small patches of the gastric and sometimes the pancreatic tissue. I was talking about the ectopic pancreas. So ectopic pancreas can be present here in the Michel's diverticulum, causing ulceration, bleeding, or even perforation. Sometimes it can lead to ulceration, bleeding, or perforations. Okay. It is a remnant of the proximal part of the non-oblated part of the yolk stalk or the vitelline duct. As we have seen, vitelline duct is the duct which is connecting. So if you see here, this is the vitelline duct, which is connecting the intestine to the yolk sac. So this will vitelline duct will become the remnant and becomes very small and becomes disappear, and it remains as the vitelline ligament. Okay, but sometimes, so here is the vitelline ligament. Sometimes it can remain as a pouch, and this is called as the Michel's diverticulum, present in almost 2% of the uh, people, 2 to 4%, and more in case of male. Okay, so it is a remnant of the proximal part of the non-oblated part of the yolk stalk or the vitelline duct. It arises from the anti-mesenteric border of the ileum. Anti-mesenteric border means where the mesentery is not present. Mesentery, the mesenteric border is where the mesentery is attached. The other free end will be called as the anti-mesenteric border. So usually it is seen in the anti-mesenteric border, 2 feet from the ileocecal junction. It is 2 feet from the ileocecal junction and in present in 2% of the people. It is sometimes, and it is said to be 2 inches. Okay, so it is 2 feet from the ileocecal junction, 2 inches in size, and present in 2% of the people. It is sometimes becomes inflamed and causes symptoms that mimic appendicitis. So we should be very careful. Sometimes this Michel's diverticulum can mimic the symptoms of the appendicitis. Okay, which is seen in case of the teenage boys and girls. So this is can Michel's diverticulum can sometimes inflame and it mimics the appendicitis. So whenever we diagnose of the appendicitis, we should be very careful that it can be because of the Michel's diverticulum also. It may be connected to the umbilicus by a fibrous cord, as you can see here, the fibrous cord, and the middle portion forms a cyst or may remain patent, forming the fistula. Sometimes the middle part might remain as a cyst, and the first and last part have become vital ligament. Sometimes there can be a fistula development of this called as the Westerling fistula. Okay, so forming vital fistula, so fecal matter is carried through the duct into the umbilicus. So sometimes there will be fecal matter coming out. If there is vital fistula, the intestine start opening and the feces will start coming through the umbilicus. Okay, so there are different types. Normally it will be like this Michel's diverticulum. Sometimes you can see a cyst. Sometimes there can be a vital fistula where the intestinal contents will start coming through the umbilicus. So here you can see again a patient with omphocyte. So this is omphocyte. Okay, and here you can see the picture of the Michel's diverticulum. Okay. Now coming to the development of the hindgut, the lowermost part of the intestine, that is the hindgut. During the 7th week, the cecal membrane uh, the cloacal membrane disappears, exposing a ventral urogenital sinus opening and a dorsal anal opening. So the lowermost part of the intestine that form the hindgut, which form the urogenital sinus as well as the anal, both the development of the urine bladder as well as the anal part. The tip of the urorectal septum separate the two openings from the perineal body. So now these two, the urogenital system and the anal system, are separated by a small structure called as the perineal body, which separate the urogenital from the anal anal opening. The urorectal septum grows toward the cloacal membrane but does not fuse with it. Okay, so it develops this urorectal septum will go up to the, there is an septum here called as the cloacal membrane. Okay, it will go up to that, but it does not fuse. It is derived from the mesoderm at the junction between the connecting stalk and the yolk sac. Okay. So here you can see here the development of the, this is the cloaca. Okay, and here you can see the development of the urorectal septum. Okay, so here is the hindgut, and here is the development of the urogenital part. So here is the primitive urogenital sinus, and here is the development of the anorectal canal separated by the perineal body. So here you can see here is the perineum, and here is the development of the bladder, and here is the development of the anal membrane. Initially, both will be together from the cloaca, but later they get separated. Now you can see here there is separation of the urogenital sinus from the anorectal sinus, and they are separated by the perineal body here. Now further development. So here you can see the bladder and the urethra and the ureter, everything. And here you can see the development of the lowermost part of the intestine, rectum, anal canal, as well as the anus here. Okay, so this whole thing is developing. So this is whole development from the hindgut. Now coming to the congenital anomalies of the rectum and the anal canal. So here you can see here the congenital anomalies. One is called as the imperforate anus. Here is the imperforate anus where there is total atresia of the lower part of the anal canal. It has not developed, and this becomes the imperforate anus. Means there is no perforation, there is no opening. The second is the atresia of the rectum. Sometimes instead of the anal canal, it is the rectum which is atresia. So there is total closure of the rectum. Okay. If you see here, there is no actually rectum is there, but it is opening somewhere else. So sometimes there will be total closure of the rectum. Sometimes there can be a rectal fistula. This is the rectal fistula, which is opening instead of into the anal canal, it is opening into the urethra. Okay, so sometimes into the prostatic urethra. Here you can see here it is opening the prostatic urethra in some male, and sometimes into the other part of the urethra. Okay, so this is the rectal fistula. So there are three types. One is the imperforate anus. Sometimes there can be atresia of the rectum, and sometimes there can be rectal fistula opening into, instead of into the anal canal, it is opening into the urethra. Okay, any part of the urethra. So this is all about the development of the gastrointestinal system. If you have any doubts regarding this, you can ask me now.